Hello everyone, and welcome to week 15, where we're going to be covering chapter 18. This is the last chapter in your book. Thank you for staying with me all 15 weeks here. The 16th week will probably be pretty much the final exam, and it will also be a discussion thread and e-lecture topic, that kind of thing. But for the most part, this is our last chapter that we're going to be doing as far as an e-lecture. And so I'm hoping that you learned a lot out of the class. And I know I had fun presenting this information to you. And I hope that you're able to carry on some of the knowledge from this class as you continue your education. All right, let's get started. So chapter 18 is Biopsychology of Psychiatric Disorders. And specifically, we're looking at psychiatric disorders, which are those that disrupt psychological functioning. They are diagnosed using the DSM, and the DSM that we're on right now, that is the Diagnostic and Statistical Manual of the American Psychiatric Association. And we are on the 5th edition on that. Okay, there's a few disorders that we're going to be going over. There's about 4 or 5. There's many more, but for the sake of this chapter, he breaks it down into schizophrenia and then the affective disorders, anxiety disorders, hits a little bit on Tourette Syndrome. So that's what we're going to be focusing on mainly. The first disorder that we're going to discuss is schizophrenia. It refers to the breakdown of integration of emotion, thought, and action. Do not get schizophrenia mixed up with dissociative identity disorder, the whole idea of having 2 different personalities, split personalities. A lot of people confuse split personalities with schizophrenia, and they do this a lot in movies and radio hosts and things like that aren't familiar with really the psychological disorder. So schizophrenia is a breakdown of integration of emotion, thought, and action, and you'll know a lot more about it by the time we're done with this chapter. It affects about 1% of the population, so it is pretty rare. It is diverse. There's multiple types, and a lot of people think of schizophrenia as the schizophrenias, and you'll see this in a little while also, because there are so many different types. It's almost like its own class of psychiatric disorder. There are positive and negative symptoms, and these can include delusions, hallucinations, etc. And only 2 need to be present for 1 month for the diagnosis. And I want you to go to page 448 and look at the positive and negative symptoms real quick. Okay, so positive symptoms, you have delusions, hallucinations, inappropriate affect, failure to react with the appropriate emotion. So somebody's like happy birthday and they don't seem happy about that. Okay, somebody close to them might pass away and they don't seem sad about that. Okay, it's an inappropriate affect. Incoherent speech or thought, and then odd behavior, talking in rhymes. One thing that they talk about was their speech is like a word salad. Okay, they're trying to read a sentence, but it's almost as if they put all of the words into a salad, tossed it all up, and then they come out of, all the words are out of order. Okay? So those are positive symptoms. Negative symptoms are affective flattening, which is a reduction or absence of emotional expression. Alogia, reduction or absence of speech. Avolition, reduction or absence of motivation. Anhedonia, which is the inability to experience pleasure, and then finally catatonia, which is motionless or awkward positions. They remain motionless or in an awkward position. So catatonia, anhedonia, avolition, alogia, those are some of them that you probably haven't been most familiar with. You probably think schizophrenia and hallucinations, delusions. So I wanted to make sure that we went over those in detail for you. Okay, there is evidence of a genetic contribution But there also appears to be multiple causes. There's no single gene that causes schizophrenia, but it does seem to be to have a genetic component, because we can look at comorbidity with twin studies and that kind of thing. Has also been possibly linked to infections or autoimmune reactions or toxins, traumatic injury, stress, kind of all over the place. It appears the interference with the normal development of susceptible individuals may lead to the development of the disorder. So what we're saying here is that maybe early stress, early toxins, early traumatic injury may predispose an individual, and yet without trying to figure out the word for it, but that trigger, yeah. But without that trigger later in life, the schizophrenia never shows up. But let's say that there has been this traumatic injury and so on, and then there's an extremely stressful event. That might be the trigger that kicks schizophrenia into manifesting itself. Discovery of the first antipsychotic drugs. Much of our understanding of schizophrenia is a consequence of the drugs that are able to treat it. First, there was chlorpromazine. It calms many agitated schizophrenics and activates many emotionally blunt schizophrenics. There's also Reserpine, which also calms schizophrenics. It has been seen as effective, but it severely decreases the blood pressure. So Reserpine is not readily used. And both drugs are not effective for 2 to 3 weeks. And after use of chlorpromazine or Reserpine, we see Parkinson-like motor effects. Okay, and so if you remember the Parkinson's disease, that was because of, remember, the substantia nigra was almost all out of dopamine. And because of this, the nucleus accumbens and the striatum, they couldn't receive that dopamine, so movement was disturbed. Okay, so now think about that. It looks like there's a link here, and that's where we're going with the dopamine theory for schizophrenia. Okay. In 1960, the link between dopamine and Parkinson's disease was established. See, antipsychotic drugs, what they do is they decrease dopamine. Okay, and so that benefits the schizophrenic because their symptoms are due to an abundance of dopamine. However, chlorpromazine, Reserpine, depleting the dopamine then caused the Parkinsonian type symptoms because it wiped out or decreased too much of the dopamine. And we know that when dopamine gets too low, there's the movement disorders or the Parkinson-like symptoms. And then you also have amphetamine and cocaine, which produce psychosis that looks very, very similar to schizophrenia. And that's because amphetamine and cocaine are causing a huge influx in dopamine. So seems very plausible that there is a link between dopamine and schizophrenia. We know that there is one, but it doesn't really tell us the whole story. And you'll find out a little bit more in as we go through the chapter that, you know, definitely dopamine is playing a role, but it's probably not the only part to schizophrenia. Okay, the higher affinity a drug has for dopamine receptors, the more effective it is. So haloperidol is an exception. While most antipsychotics bind to D1, D2, like your chlorpromazine, it and other butyrophenones, okay, butyrophenones bind to D2. See, chlorpromazine antagonizes dopamine activity by binding and blocking dopamine receptors. All right, and so what in psychopharmacology, it is all about selectivity. It's all about designing drugs that only affect a particular type of receptor, and so you're not going to have those huge contraindications if you can limit your drug to just binding to, let's say, D2, and I believe there's 4 or 5 subtypes of dopamine. So let's say just D2. Well, you leave D1, D3, 4, and 5 untouched, you're not going to have as many ill effects. And here it is in a figure. It says chlorpromazine binds to the postsynaptic dopamine receptors. It does not activate them, and it blocks the ability to dopamine to activate them. Okay, so chlorpromazine fits into that receptor site like a little lock and key, and then blocks out any dopamine that's trying to get in there. The blockage of dopamine receptors by chlorpromazine sends a feedback signal to the presynaptic neuron, which increases the release of the dopamine. So you have a lot of dopamine in the extracellular fluid. And then the feedback signal increases the release of the dopamine, which is broken down the synapse probably by degradation, enzymatic degradation, okay, into dopamine metabolites, which are not going to be an active transmitter. Here's another graph here that shows the positive correlation between the ability of various neuroleptics like haloperidol, chlorpromazine, spiroperidol, and you'll notice here that spiroperidol actually has the highest potency to D2 binding. It's up there very, very high. Haloperidol would be second, and then chlorpromazine all the way down there at the bottom. Okay. Now, there have been several other drugs developed, like your clozapine, which is an atypical neuroleptic. It acts at D1, D4, and also serotonin, okay, but has only some binding to D2. So it is specific to D1, D4, and then it brings in serotonin. Schizophrenia is associated with brain damage also. The damage is not explained by the dopamine theory, and neuroleptics are only effective for some people. So here's where it's kind of getting messy. We focused a lot of our time on dopamine, maybe more at D2 than D1, D4. But now we're looking at, oh, well, there are drugs like clozapine that actually work on serotonin and seem to be effective. So maybe it's not entirely dopamine. Then we're looking at the brain damage, and we look at these brain scans, and we see that the schizophrenic brain is different. So is it due to a loss in neural tissue? And so that would be something in addition to the dopamine theory, right? And then you have neuroleptics that aren't always effective for schizophrenics. And if it was just a dopamine issue, then that wouldn't make sense. Okay. Conventional neuroleptics, those that are the D2 blockers, your chlorpromazine, are mainly effective for positive symptoms. Negative symptoms might be caused by brain damage, but we don't know. And then here's where you're author Brian, the positive and negative symptoms, but I wanted to give you more detail than that, and that's why I already mentioned them earlier. And it may be best to think of schizophrenia as multiple disorders with multiple causes, and that's where I came up with that term, schizophrenias, because there's multiple disorders here, part of the disease. Okay. Atypical neuroleptics treat some symptoms of schizophrenia without directly affecting D2. Studies examine the effects of psychedelic drugs as modeling positive symptoms, and dissociative anesthetics like ketamine as modeling negative symptoms. So if you think about this, the psychedelic drugs, what do? They cause hallucinations and delusions and so on. So maybe there is more of a serotonin component, because we know that like drugs like mescaline and so on increase serotonin levels a lot. Well, maybe we should look at drugs for schizophrenia that decrease those serotonin levels. Okay, and that might help with the positive symptoms. Genetic marker research is mixed, but shows some relationship between proposed markers for schizophrenia and other psychiatric or neurological disorders. And there is a consistent link between damaged brain tissue and schizophrenia. So let's look at that. Okay. Oh, actually, I added this slide here because I wanted us to go over in table 18.1. It's a nice summary for us. It says, in the early 1950s, the anti-schizophrenic effects of both chlorpromazine and Reserpine were documented and related to the Parkinsonian side effects. That's where we started. And then late 50s, the brains of recently deceased Parkinson's patients were found to be depleted of dopamine. And that's where we found out, oh, well, wait a minute here. Maybe we need to be very, very careful with chlorpromazine because now we're causing this other disorder. In the 60s, it was hypothesized that schizophrenia was associated with excessive activity of dopamine, right? 60s, 70s, chlorpromazine and other clinically effective neuroleptics were found to act as a receptor blocker for dopamine. And then the mid-70s, the affinity of neuroleptics for dopamine receptors was found to be only roughly correlated with our anti-schizophrenic potency. Late 70s, the binding of existing anti-schizophrenic drugs to D2 receptors was found to be highly correlated with their potency. And then 80s, 90s, it became clear that the D2 version of the dopamine therapy of schizophrenia cannot account for all the research findings. And this is something that's a little sobering, and your author brings that up, is that you see this is 1990s. We're now dealing with, even at the end of 1990, into the 2000s, we're looking at 17 to 20 years, almost 25 years, with very little, there's a lot of psychopharmacology research going on out there, but it's kind of disappointing that we haven't been able to come up with something that is dramatically better than what we have with these. So haloperidol, some of these drugs are still going to be used for schizophrenia, and even though we know that they have those adverse effects. Okay. And then figure 18.3, if you look at the bottom there, you'll notice that the black area is right in the middle. Okay. On the left-hand side, you'll see the two black on here, it kind of looks like two eyes, I guess, if you want to look at it that way. But the two dark circles right in the middle of the picture, those are the lateral ventricles. So you notice how those lateral ventricles are much larger on the left-hand side in a schizophrenic than they are in a healthy tissue. Okay, so anytime you have larger lateral ventricles, you're going to have less brain tissue. So you'll notice, especially in the white area there, where all that myelin is, all the white matter, right? There's a lot more white matter in the brain on the right than there is on the left. And that's what we're looking for as far as the brain damage due to schizophrenia. Okay, so now let's look at affective disorders. Right. Depression, normal reaction to loss, abnormal when it persists or has no cause. Most of these psychological disorders are on continuums, right? So everybody becomes anxious, everybody gets depressed, everybody has a manic moment, if you want to call it that. But it's on a continuum. It's how severe it is. It's how detrimental it is to one's life or keeping their job, their family together, that kind of thing. Okay. So depression, normal reaction to loss, but if it doesn't go away, then it can become abnormal. Mania is overconfidence, impulsivity, distractibility, and high energy, and you'll see where these play into one another. So affective disorders are psychiatric disorders characterized by disturbances of mood or emotion, also known as mood disorders, and they include depression and mania, and we just described both of those. Types of depression, you have unipolar and bipolar. Unipolar is going to be just depression. Bipolar is going to be depression mixed with manic episodes, okay, or mania. You can also characterize them as reactive. Reactive depression is it has a source. Somebody lost someone. Endogenous is that there is no source for the depression, no apparent cause. Okay. Affective disorder is very common. Approximately 5% of people suffer from unipolar affective disorder, and approximately 1% suffer from bipolar. The concurrence rate is higher for bipolar than unipolar, but there is no particular gene that has linked these affective disorders. So, how do they come about? Well, stressful experiences. Evidence linking stress and affective disorders is sparse. Extreme stress is more likely to cause post-traumatic stress disorder than depression. There's also seasonal affective disorder, wintertime depression, and lethargy, probably due to reduction of sunlight. It's more common in the north than in the south, and light therapy does help. So those are indications that light plays a role in this depression, and we call it seasonal affective disorder. So how do we treat these affective disorders? You have the monoamine oxidase inhibitors. Okay, we talked about those way back in chapter 4 a little bit. Okay, oxidase is going to be an enzyme, and so it's an enzyme that tears apart the monoamines. So MAOs are going to be the antagonist to monoamine, and the monoamine oxidase inhibitors are going to be inhibiting the enzyme so that you actually have more. So MAOIs are going to be your agonist. One of those is ipronizid. Yeah, that one is always a tough one. Ipronizid. It prevents the breakdown of monoamines, and it must be avoided because of its relationship with tyramine and the Ch effect. And what happens here is that you have a very, very potent elevation of blood pressure. So if you are on an MAO inhibitor, you have to be very careful with your diet. Now, the tricyclic antidepressants, like imipramine, they block the reuptake of serotonin and norepinephrine, so they are safer than the MAOIs. Okay? They block the reuptake of serotonin and norepinephrine, so that means that they're agonists, right? More serotonin, more norepinephrine. Then there's also selective serotonin reuptake inhibitors. These include Prozac, Paxil, Zoloft, many of the names that you see on probably commercials and so on. They are no more effective than tricyclics, but the side effects are few, and so that's why they are used a lot. And there are also selective norepinephrine reuptake inhibitors. Okay, so that means that for the SNRIs, they are going to be agonists for norepinephrine, causing more norepinephrine. Selective serotonin reuptake inhibitors cause more serotonin. Okay. So they're agonists. Here's an example here. Serotonin is deactivated in the synapse by reuptake into the presynaptic neuron on the left-hand side there. And then on the right-hand side, you see Prozac, which is blocking that reuptake and therefore increases the activation of serotonin receptors. Also, very, very quickly, your author doesn't spend much time on this at all, but he does talk about lithium as being a mood stabilizer for bipolar disorder. It is one of those things for that pretty much all psychiatrists believe that if the individual is bipolar, they should be on lithium. Okay. Very, very few things are that defined in psychopharmacology, but it is one of those things here where they definitely believe that lithium can help the bipolar individual. Okay. Results are about the same for MAOIs, tricyclics, and SSRIs, about 50% improve compared to 25% of controls. So they are effective, but they're all about equally effective. In 2008, meta-analysis indicated that placebo was about 82% as effective as antidepressants in severely depressed individuals, and drugs are even less effective for mild to moderately depressed individuals. Okay? So it's one of those things where these medications, they should definitely be taken with some kind of therapy, so that they can, the individual can identify what their stress response is and how to relax better and those kinds of things. Because here, 82% as effective as antidepressants, that's a placebo, right? So that's something to consider. All right, what about the brain pathology? There is inconclusive evidence for the reduction of size of the brain or its individual components due to bipolar affective disorder. Remember, we talked about the brain damage, the visible damage that you can see in the schizophrenic brain. Okay, we cannot see that same thing in the affective disorder brain. Reports of shrinkage of the amygdala, cingulate cortex, and prefrontal cortex have been seen in some studies. Most consistent findings with the amygdala and anterior cingulate cortex. And I have a chart to show you that. Okay, so structural MRIs of healthy volunteers with a genetic predisposition to developing depression reveals cell loss in the anterior cingulate and the amygdala. So left hemisphere, right hemisphere. The blue areas are going to be significant cell loss. The red is going to be greatest cell loss. And so again, medial prefrontal cortex is where the cell loss looks like it is, and the amygdala. But again, it's not nearly as straightforward as it is with schizophrenia. Okay. The monoamine theory here. Underactivity of serotonin, that's pretty obvious, and norepinephrine, because we just talked about the SSRIs, we talked about the SNRIs. Those are both agonists. Those are both chemical or drugs that are being used to increase either serotonin or increase norepinephrine. Depression untreated with drugs may result in proliferation of monoamine receptors, which is called upregulation. The idea being here is that if there's a decrease in dopamine, okay, there will be an upregulation or an increase in dopamine receptor sites, because the brain is trying to okay, well, there's not as much dopamine out there. I'm going to create more of these receptors so that I can try to increase the amount of dopamine that comes in. It says when insufficient amount of a neurotransmitter is released at a synapse, there are usually compensatory increases in the number of receptors for that neurotransmitter. And that process is called upregulation. Problem with the theory, not all depressed people respond to monoamine agonists. Okay? So again, same issue that we have here with the dopamine, right, and the chlorpromazine hitting the D2 receptors, and doesn't help all schizophrenics. Okay, the diathesis stress model. Diathesis is a genetic susceptibility, but when there's diathesis plus stress, then that might equal depression. Support is indirect. Depressed people tend to release more stress hormones. Okay? So again, that kind of goes back to what I was mentioning to you with having a predisposition for something and then having that stressful factor, which acts as a trigger. Okay, now they have, this is just fairly recent here, where they're looking at electrical stimulation near the anterior cingulate gyrus. And this has provided relief from depression, and they've actually been doing studies, and they have been able to replicate the same findings. So there is the anterior cingulate gyrus plays a role. Remember, we talked about the cell loss in that area, and now we're looking at an electrical stimulation near that. Remember, this is similar to the whole Parkinson's disease issue and the electrical stimulation in the substantia nigra to try to get more and more of that dopamine to be released. Okay, so same principle here. And there's your anterior cingulate gyrus, and that's the area that they're stimulating. Okay, and then other treatments, just to kind of finalize this section here. Sleep deprivation. More than 50% of depressed patients improve after one night of sleep deprivation. Depression returns with normal sleep pattern. This effect is not explained by any current theory, but that's something that they're looking at. And exercise helps reduce depression, increases adult hippocampal neurogenesis, and findings suggest that depression may be caused by reduced adult hippocampal neurogenesis. Okay, so get good sleep. This isn't saying, well, you need to sleep deprive yourself, but it's improved after one night of sleep deprivation. This is a continual sleep deprivation. You need to get your good night's sleep, just like we learned about in previous chapters, and you need that exercise. Okay, so let's keep moving on. We went through the schizophrenias, if you want to term it that way, and we went through the affective disorders. Now we're going to hit anxiety disorders. Anxiety, fear in the absence of threat. Again, on a continuum, are we all fearful? Yes. And should we be fearful of certain stimuli? Yes. Anxiety disorder is when the fear is not there, the fear is not real, we cannot stop thinking about something, and so it causes the anxiety, disturbs our sleep, disturbs our work, etc. Accompanied by physiological symptoms, there's tachycardia, which is the fast heart rate, hypertension, sleep disturbances, and nausea. And it is the most prevalent psychiatric disorder, your anxiety disorders. 5 classes of anxiety disorders. You have the generalized anxiety disorder, stress and anxiety in the absence of a causal stimulus. These are the people that just they're always kind of on edge. They might hum to themselves like, because it just, that kind of calms them down a little bit, but they're always kind of on edge. They're always worried something's going to happen. Phobic anxiety, similar to generalized but triggered by particular stimulus. Most people know their phobias. Panic disorder, attacks of extreme fear and stress. Obsessive-compulsive disorders, and then post-traumatic stress disorder, pattern of psychological distress, and post-traumatic stress disorder talked a lot about in the news and so on from individuals coming back from war and so on. No specific genes have been linked to anxiety disorders. So remember, we had that there must be a strong genetic component. We just haven't found it in schizophrenia, right? There's no single gene. There's no single gene for the affective disorders. There's no specific genes for anxiety disorders. The role of life experiences is critical, though. Okay, so stress. Remember what we talked about in the last chapter. Stress experienced at a very early age can oftentimes predispose somebody so that they can't deal with stressors nearly as much, so they get very anxious, right? When you haven't had a good experience with something and it keeps happening to you, it causes distress, right? If something for whatever reason happens to you, but you're able to deal with it, it's like, oh man, I've done this 100 times. I'm just gonna, not even worry about it and just move on. And those people, that stress does not get to the point of distress. Okay, so how do we treat the anxiety disorders? You have the benzodiazepines like Librium, Valium, also used as hypnotics, anticonvulsants, muscle relaxants. They are GABA agonists. Remember, GABA is the most prevalent inhibitory neurotransmitter. Serotonin agonists also. Buspirone, SSRIs, reduce anxiety without sedation or serious side effects. And antidepressants are effective due to the comorbidity of anxiety and depression. The key component here is that many people who are depressed are also anxious. Many people who are anxious are also depressed, working on the same level here, and so therefore these drugs like your SSRIs, the antidepressants, are also oftentimes given for the anxiety disorders. Some animal models and how we've been able to study anxiety. You're looking at the elevated plus maze test, the defensive bearing test, the risk assessment test. So if an animal avoids open radial arms in a maze because it's elevated and they might fall off, that causes fear, right? If they act like they're burying themselves, then they're stressed out. They're fearful of something. If they freeze, they're fearful of something. So we know these are all manifestations of fear or anxiety. So what we can do is we can come up with drugs now that we give these species to see if in the face of that same fear or anxiety causing stimuli, they don't show, right, the burying behavior or the freezing behavior. And benzodiazepines do work for that. We have seen that in animal models. All right, drugs suggest a role of serotonin and GABA. We already talked about that. The amygdala, due to its role in fear and defensive behavior, is thought to be involved. Remember, again, this all goes back to our limbic system, right? We still talk about the amygdala and the anterior cingulate and those things because we're talking about emotion still. There's some evidence for overactivity in the amygdalas of patients with phobias viewing the fear objects. Excuse me. I had a sneeze there. All right. Okay. And then the last thing we hit in this chapter is Tourette Syndrome. A disorder of tics, involuntary movements, or vocalizations. Begins in childhood, does have a major genetic component. It does seem to get worse into adulthood. These individuals oftentimes are also ADHD or OCD, obsessive-compulsive, right? There are no animal models, though, for Tourette syndrome. So like we were just talking about with the anxiety disorders, the animal that's burying itself, okay, we can identify that as anxiety. Well, we don't have a Tourette syndrome model in animals, so it's going to be much harder for us to work with this one to find psychopharmaceuticals that are going to be effective. Patients tend to have a smaller caudate nuclei. There's evidence for the thinning of the sensory motor cortex, and we'll see those areas in a minute. Okay. Structural MRIs reveal thinning of sensory motor cortex in children with Tourette syndrome. Red and yellow indicate large areas of cortical loss. The red and yellow areas. Okay. So you'll notice that on the top right there, you're looking at an individual who's facing the right-hand side. And so you look at the sensory motor cortex in that red area there, and that is the cortical loss. Okay, so how do we treat this? Oftentimes with neuroleptics, and the effectiveness of D2 blockers suggests abnormality in the basal ganglia-thalamus cortex feedback circuit. Okay, the basal ganglia, remember movement disorders, basal ganglia to nucleus accumbens, basal ganglia through the thalamus switching station to the cortex, and primarily nucleus accumbens, that area is going to be for the movement disorders. So try to decrease the dopamine in that area by using D2 blockers. Okay. Translational research designed to translate basic scientific discoveries into effective clinical treatments. Usually moves to clinical trials of the treatment. The idea being here, before we get into the phases, the idea being here is that it is oftentimes very hard for us to translate what we identify in a animal subject in a lab in a very controlled situation to an individual who is living their life in the real world, eating, drinking, doing whatever they want to do, where there's all these other factors, right? Stressful environments, etc. So it's very hard for us to translate what we find in a lab to the real world, but that is our entire purpose of psychopharmacology. So here, look at the phases of drug development. Here you have basic research, discovery of the drug, development of efficient methods of synthesis, primarily done on animal subjects. I alluded to this in Chapter 5 when I talked about the different ways of studying these things. I worked in a physio lab, an animal lab, where we were doing basic research and looking at drugs at the very, very beginning of their infancy, just to see, were they agonists, were they antagonists, did they cause synergistic effects? How can we use these substances to better the human life or human condition? Application to begin clinical trials and review of basic research by government agency. Then you have the human clinical trials, phase 1, screening for safety and finding the maximum safe dose, establishing most effective doses and schedules of treatment, clear demonstrations that the drug is therapeutic is finally phase 3, and then application to begin marketing and review, and then selling to the public, recovering developmental costs and continuing to monitor the safety of the drug. And this, it's not a timeline here. Most of the time the books show you timelines. I guess in figure 18.11, the cost and duration of the 3 phases, there we go. And you're looking at phase 1 takes about 15 months, phase 2, 30 months, and phase 3, about 27 months or so. So 3, 6, 7 years, 6 to 7 years is what you're looking at for some of these drugs. Okay. There's also a lot of controversy around the clinical trials because, as you know, you watch these commercials on TV and you say, well, man, there's so many contraindications, so many ill effects, right? But at the same time, you know, how is it benefiting those other individuals? Their conditions might be so severe that without this medication, they really have no way of life, right? So there's this point of, you know, these psychopharmacologists are saying, well, this drug can definitely help people. It can definitely help people. However, I haven't done a double-blind design. The placebo controls, it's not a lot better than placebo, but it is a little bit better than placebo. And so then it becomes this policy thing, right? Or how much better does the drug have to be above placebo? Does it have to be 20% better or 30% better? And so, you know, do you have to do a double-blind design? Or I know it's effective. I can see the change in these people, you know, but I can't mass produce this drug because it just hasn't finished all of these tests, right? There is a need for active placebos, which have side effects but no therapeutic value, and the length of time required, like we said, 6 to 7 years. So those are all issues to think about. There's also financial issues, conflict of interest, right? The drug companies want these drugs to come out as soon as they possibly can. They have to recoup the cost that they've spent, the hundreds of millions of dollars that they've spent on testing these things. There could be an orphan drug problem, which means that they come up with a substance that is just phenomenal. It works excellent, but it's only good at a very, very rare disorder, right? How do you mass produce that? There might be only a couple people that even work with that drug, and it's not going to be cost effective for the pharmaceutical companies to mass produce something like that. So run into an issue. Translational bottleneck. Due to high cost of clinical trials, few scientific findings translate to new drugs. And then there's a your author put in this individual here. Clinical trials can be trustworthy, fast, or cheap, but in any one trial, only 2 of the 3 are possible. So many things to think about there. Okay, and then that is it for Chapter 18. Again, thank you for your diligence, and hopefully the class has benefited you. I'm hoping that you can take this knowledge with you and apply it in other courses, and I hope that the delivery was good for you guys. It did require a lot of time to go through the PowerPoint slides and change the PowerPoint slides based upon the data that I wanted you to know, and then do the voiceover for the e-lectures. But I thought it was a great opportunity for us to connect a little bit better, from aside from you just going kind of to a website and doing your own thing. It did provide me the ability to guide you through the process, and there's still going to be a couple more weeks of the class. I would highly encourage you to try to get in on one of the collaborate sessions and see what we do there. But other than that, all we really have is your e-lecture topic item, and that's going to be number 2, which is judge people by what they do, not by what they say. Discuss this recommendation with respect to Tourette Syndrome. And this, again, just like e-lecture topic item number 1, is worth 10 points, and I'm going to need at least 1 or 2 paragraphs dedicated to this for your full points. Thank you.